There's a lot happening in the world of cancer, but our goal with our platform has been to reiterate the current standard of care. Tonight, we're focusing on taking a deeper dive in the second-line treatment of renal cell carcinoma. What next after that upfront IO-TKI combination? Hello, everyone. I'm Rahul Gossain, here with my brother and your co-host, Rohit Gossain. We're two practicing community medical oncologists, and we're the host of the Oncology Brothers platform. With today's topic in hand, we're excited to welcome three medical oncologists, Dr. David Braun from Yale University, Dr. Ulka Vaishampayan from the University of Michigan, and Dr. Bradley McGregor from Dana-Farber Cancer Institute. David, Ulka, and Brad, thank you for joining us.
David, Ulka, and Brad, welcome. Before we walk through our treatment options in second line, that is refractory relapse setting of RCC, let's set the foundation where we stand with advanced RCC today. That is, we have IO-TKI combinations, that is pembro-axi, nivo-cabo, and then pembro-lenvatinib. And then we have mature data with dual checkpoint inhibitors as well. But with all this, keeping that our treatment intent is palliative in nature. So at the time of progression, keeping few things in mind is important. That is, data post-IO exposure, tolerability aspect of it, sequencing in second and third line. I acknowledge that a lot of new data is being thrown at us today. But let's focus on where we stand from standard of care options. David, can you start us off here? Where do we stand from our treatment options in relapsed refractory setting? And what do we have from NCCN standpoint and pros and cons on available options?
Yeah, absolutely. I think you bring up some really good points. And, I always like to clarify that the intent in the first line setting might be quite a bit different than that treatment refractory setting. In the first line setting where you have immunotherapies, there's still the hope for that long-term, very durable, potentially some people use the word even cure, though it's unfortunately not common enough. But once you move past that and you're in the refractory setting, you're absolutely right. It's palliative in nature and you want to extend life as much as possible, but also make quality of life a priority as well. And that's how we have to think about options. So with that in mind, what are the options after a frontline IO-based therapy? It is largely TKI-based, and I'll give the one maybe slight exception there. So after a frontline IO-based regimen, standard of care regimens include cabozantinib, lenvatinib plus everolimus, axitinib, and tivozanib. The one thing I'll add is if someone got an IO-TKI regimen, specifically an IO-TKI regimen, that frontline, belzutifan is also a possibility in the second line. All of those are acceptable, recommended options per the NCCN guidelines.
David, in terms of pros and cons of these available options, because we're often stuck doing cross-trial comparisons, and what's the data after IO in hand here?
A lot of the initial trials, like if you look at the AXIS trial for axitinib, you look at study 205 for lenvatinib plus everolimus, those were largely in the era prior to when IO-based therapy was available. So we have to do a lot of mental extrapolations to really look forward. I think some of the more modern trials, like Tivo3, included a number of people that were previously treated with immune checkpoint inhibitor. And then we even have data from the most recent trials, Contact-03 or Team-Evo2, where we really have data on how well these drugs work in the post-IO setting. And as you're saying, what are the toxicities like? Because that balance is particularly critical. It's important at all steps, but particularly critical in that second line and beyond setting.
Absolutely. Thanks, David, for getting us started. Sequencing in our clinic often ends up being, Rohit, you got us started with this IO-TKI or dual checkpoint inhibitors. And then given data for Tivo3, Tivozanib, which is based off PFS, and then belzutifan, which got approved based off LIGHTSPARK 005 study. After that, we're often circling back with our other TKIs with or without everolimus. Ulka, can you touch on where does Tivozanib fit in for you, given our current second-line treatment options and the data around Tivo3, as David brought that up?
Tivo3 was a clinical trial that randomized patients post at least one prior therapy to get either sorafenib or another TKI, Tivozanib standard dose. The standard dose is 1 tab daily for 3 weeks on, 1 week off. Sorafenib was given 400 milligram twice a day, starting dose continuously. The primary endpoint of the study was progression-free survival, and Tivo3 showed that Tivozanib surpassed sorafenib in terms of the primary endpoint. So statistically significant benefit was seen with Tivozanib. In addition, the tolerability of tivozanib, a very specific VEGF blocker. So because of that, the toxicity profile is not broad, and the typical TKI related toxicities, hypertension, hand-foot syndrome, etc., are seen, but on a much lower proportion of patients. So overall, it's a tolerable regimen. It showed a response rate of about 18%, but 55% had stable disease. So all in all, about 3 out of 4 patients were having some kind of clinical benefit. The other thing that came out of the TiVo-3 study is that the regimen produced a durable benefit. If patients had a response or tumor shrinkage, they tended to last quite a bit. So PFS for the patients who did respond, half of them at least maintained it for 2 years or longer. So that data was very impressive in terms of the durable remissions that were induced with tivozanib and the balance of the tolerable toxicity profile. So you could sustain the patients on treatment for this prolonged period of time if they were getting clinical benefit.
Thank you, Ulka, for covering that. I know this came up initially when we were talking to David, that is the treatment is palliative in nature. So toxicity profile of TKIs is always a major focus. All these TKIs come up with their own fair share of side effects. As targets vary, so does the toxicity profile. And what is important, what we saw from TiVo-3 was, with tivozanib, that 80% of the patients stayed at that full dose, whereas with other TKIs and other treatment options, there has been dose reduction, and response here varies based on the dose. So Brad, with regards to the side effect profile, if you could go where do we stand, how do you manage some of these toxicity profile for TKIs and other agents here in second line?
Yeah, I think the toxicities are a key thing. We start thinking about that second, third line therapy, because as we heard, like our goal is to get patients the best quality of life for as long as possible. That toxicity profile is super important. And I do want to comment, we use TiVo all the time. If you look at the TiVo-3, it says 1.5 milligrams daily. That we use 1.34. It's the same dose. So don't think that we've changed the dosing. It's just a different formulation. So I think it is important to realize that the TiVo-3 dose of 1.5 milligrams is equivalent to the 1.34 dose that you're going to be using in the clinic today. And that's dosed down to 0.89 milligrams day 1 through 28-day cycle, and then every other day if needed. Because I get a lot of questions about that. And as you look at it, it can sometimes get confusing. But that being said, when we use tivozanib, and it's Ulka's alluded to, I think it's probably one of the cleaner VEGF TKIs. It has much more potency for the VEGF receptor. Some of the hypertension is a little bit higher when you look at TiVo than maybe some of the other TKIs, but we do have less of the diarrhea, hand-foot syndrome, especially when you do that. And I would point out, TiVo-3 was a trial where they went tivozanib against another active TKI, right? We're looking against sorafenib. This is a drug with activity. And so I think that is really important, and especially to that toxicity standpoint, right? Quality of life. Now you're comparing a TKI versus another TKI, and we see that difference in tolerability. And I think it is well tolerated. Hypertension does happen. That is probably one of the most seen side effects of tivozanib. Early modifications, medications to adjust are going to be critical. Beyond that, I think it's the standard VEGF TKIs, although albeit at a lower rate. As you pointed out, I think we look at TiVo-3 and the more competitive data of TiVo-2, the dose reductions are quite low, 20%, which compared to other TKIs is probably a third less of what we see. You said dose does matter. Even if you look at the TiVo-2 trial, given concerns for hypertension with IO, they randomized patients to nivolumab with tivozanib at 0.89 versus full dose tivozanib, and outcomes are numerically better with full dose TiVo, highlighting that getting that dose is important upfront. And so I think it is critical. So I think that does separate it out from the others, that nice week off. All these TKIs have their own side effects. And, we think about off target. I'm not sure there's so much off target because maybe some of these other pathways are just as important for the kidney cancer as others. And so as we decide, we really look, what did they get frontline? What targets have they been exposed to in switching to others? As you alluded to, belzutifan is the other drug that's out there. This is not a TKI. This is a very unique toxicity profile. Anemia near universally occurs to some extent. And then we worry about hypoxia, and patients may not even feel that, right? So they may not even feel short of breath, but you check a pulse ox, it's 78% or 85%. Educating patients about that is going to be critical in the clinic. And then looking for the future, I think potential combinations of these agents will likely be at the forefront.
Thanks for covering that, Brad. Can I push you a little? If you encounter, say, hypertension with tivozanib or hypoxia with belzutifan, how are you managing that? Are you going to reduce some of the doses? Are you skipping the dose, or rather manage hypertension and still continue on with the same dose, particularly for tivozanib?
Yeah, hypertension is one of those side effects that unless it gets really high, grade 3 over 180 or something like that, I tend to say, okay, let's make sure you're on the right medications, maybe hold it for a day or two and then go on. If you look at the package insert, they say hold for up to 5 days, control the blood pressure, and resume at the same dose. So hypertension alone usually isn't a need to reduce the dose, but I think it does get the point of when you start patients on these agents, it's really important to have this discussion before you even start. You're starting the drug, say, listen, these are the side effects we expect to see. It's okay if this happens. Let me know, because if we intervene early, we can start you on additional medications and keep you on the highest dose. You don't need to be a hero and suffer through these side effects, right? And so I think that really is important. To belzutifan, I get a little bit more worried about hypoxia. I think anemia, we monitor, we can often use erythropoietin support as the iron levels are up to date, dose hold, transfusions. But hypoxia is one of those things, if a patient gets hypoxia, it's really important to hold the drug. And before you even start, look for those other causes that may perpetuate hypoxia, right? So if a patient has underlying sleep apnea, belzutifan can certainly exacerbate that fatigue and that sleep apnea. If they have underlying COPD, it could be worse. So educating patients about those upfront and then being quick to monitor that pulse ox at home, because patients often don't complain of shortness of breath. They may complain about headaches or a little bit of fatigue. And so it's important just to tell them upfront, have a pulse ox, check it a couple times a day, not like 24/7, but if you're noticing a change in that, give us a call, hold the drug.
I think Brad brings up a really important point, which is that not all side effects are created equal, in the sense that you can have something like hypertension that might be common, but that's fairly manageable. You can add lots of different antihypertensive drugs, and that's manageable. For TKI, some of the things I find hardest to manage are things like fatigue, the things that are grinding that just prevent people from having their day-to-day activities. Sometimes the hand-foot skin reaction, you try all your creams, your urea-containing cream, your steroid creams, but they just can't walk in the same way that they did before. Those are things that are really difficult to manage on an ongoing basis. And I again, looking at the TiVo3 data, the TiNivo2 data, I think those are areas where we really see substantially lower rates than some of the other TKIs. It's always hard to do these cross-trial comparisons, but I think that's been my anecdotal experience as well.
Thanks for covering all that, David. And Brad, to what you mentioned, educating patients so they know what to expect. And David, coming to you, with regards to the hypoxia, that can be debilitating, especially when it's happening right there in front of you, especially for patients and their family as well. Any important clinical pearls around this, with dose reduction, skipping the dose, or continuing on with the same dose?
Yeah, absolutely. For belzutifan specifically, hypoxia is one that you really do want to monitor. I do want to dispel the myths. It's not that everyone gets hypoxic. It's still a minority of people. If you look at LightSpark 005, a minority of people get hypoxia. But of those that do, a substantial number are high grade. So it really is a serious thing. And so I think, like Brad, I have all my patients get a home pulse ox so they can measure it at home. Because in my experience, a lot of the time it's silent. They're not actively feeling short of breath. It's that when you come to clinic and all of a sudden the O2 sat is 80. And so I have them monitor at home. And what I typically do is if that comes up and it's a substantial hypoxia, whatever reversible factors we try to reverse, but if there's no infection or concurrent illness, then it's really about holding the dose, supplemental oxygen is needed, and then when you restart it, restarting it often at a reduced dose from the 120 down to the 80, and if needed, down to the 40.
David, can I just piggyback on what you said? Not all side effects are the same, but even not all TKIs are the same, right? Rohit, on our end, we covered tox check discussion for ROS1 TKIs. Again, those are TKIs targeting ROS1 in lung cancer. So given the target's different, those tyrosine kinase inhibitors have different side effects. When you're talking about HIF2 alpha inhibitors, your side effects are different. Okay, so to put all this in context, data, side effects, and efficacy in hand, Ulka, after upfront IO-TKI treatment, intuitively, we might feel let's attack the cancer with a different mechanism, such as HIF2 alpha inhibitors, right? And then come back to our TKIs. I know you touched on this sequence initially, but do we risk losing disease control by abandoning the TKI class too soon? Should the right approach still be potentially less toxic TKI like tivozanib, or should we move straight to an alternative mechanism of action here?
I agree. I mean, I think consideration of a TKI in the second line setting is something that is, top priority, mainly because there is a quicker chance of response. So if you have a symptomatic patient or impending symptoms from a liver full of cancer, those are the places where you really want a TKI to give you a quick tumor shrinkage and, get the patient out of that so-called danger zone. Again, the side effect profile, of course, you have to monitor the high blood pressure and blood pressure monitoring every day without waiting until it becomes symptomatic is going to be critical here. The diarrhea and sometimes mucositis, those are things that you have to watch for. And of course, hand-foot syndrome, it is better to prevent it, reminding patients about being obsessive about moisturizing their skin, doing skincare is going to be a critical piece of that. I do think there is a place for belzutifan in some patients who, if initially they've had a TKI and IO, and you've noticed significant problems with tolerating the TKI, where you won't be able to sustain a TKI at a reasonable dose in the second line setting. Tivo is better tolerated than cabozantinib or lenvatinib for that matter. But if you've used cabo or len in the front line and have had serious side effects, I would hesitate and be more likely to go to belzutifan in that setting. Belzutifan, I was also going to add that if I've seen anemia, I've been able to do erythropoietin levels, and usually they're low because of the side effect of the medication, and I've been able to sustain the dose with giving the patients EPO. But, again, there is a small proportion of patients who cannot stand the anemia or the low oxygen levels. And especially people with lung mets, recurrent pleural effusions, I worry about them because they don't have the reserve to stand that. So those are multiple, from a tumor standpoint, as well as patient tolerability standpoint, things to consider.
Absolutely. As a general medical oncologist, we're treating everything from RCC here, but also endometrial cancer where lenvatinib at a higher dose is approved. We're also treating neuroendocrine tumor where we now have cabozantinib. These TKIs, they come along with good, fair share of side effects. Brad, anything to add here from your perspective in terms of sequencing? Any insights on how to best expose this disease to multiple lines of treatment in real world?
Yeah, I think to that point, as we've alluded to, we don't have cross-trial comparisons. We have a lot of data for these different combinations. I think belzutifan is unique in its side effect profile. It's also unique in its efficacy in that there are durable responses, but there's over 30% progressive disease is best response. So if I'm in a situation where I'm worried if they don't respond, they're not getting the next line of therapy, I'm going to be less inclined to do belzutifan. And then we start looking at Tivo, Cabo, Len/Ev. I think Len/Ev, we all know, is associated with more side effects, although in a small randomized phase 2 trial discussed at ESMO, outcomes were better when you look at PFS response rate when we do Len/Ev versus Cabo, albeit at the expense of toxicity. And so to that same point, right, we're left in a situation, what are we looking at? And if we're in a situation where someone's disease is causing a significant burden of symptoms, you may need to go with something that has more toxicities to get better disease control in the short term versus the other way around. And so I think it does come down to that discussion with the patient overall. I will also point out that it's really hard to compare a PFS on one trial to the other. Even if we look at TiVo-3 versus data for Tivozanib in TiVo-NIVO-2, in TiVo-2, those patients who had Tivo at second line did much better than those who had it at third line. Some of these PFS are relative to what patients had in the preceding therapy. So I think it just comes down to the patient, and our goal is to give the patients the treatment that's going to control their disease with the least toxicities. And so that just comes down to that discussion with the patient. I think Tivo walks a nice balance between good efficacy with a favorable toxicity profile, whilst drugs such as Len/Ev have the highest toxicity profile. But, based on what we see, our intuition is probably right, maybe slight good efficacy. And so it does come down to that discussion with the patient. And again, I think just to emphasize, educating the patients on what to expect, what's going to be seen with each drug. And our hope is that, we know none of these drugs last forever. Choose the drug that's going to allow you to do that drug so you can always do that next line of therapy if that doesn't work. And so how you choose that really comes down to where is the patient right now? What can they tolerate? What's the disease progression?
Add to Brad's point, which is another reason I think toxicity matters here is because it allows you, a good toxicity profile allows you to stay on drug. And I always sort of think the one that has a theoretically high potency that you can never take because it's too toxic and you're constantly doing dose holds and dose reductions, that's ultimately in the real world going to have less efficacy for our patients. In terms of what I would typically do, it depends a lot on what I've done in the first line setting. In the first line setting, if I've done an IO-IO combo, which is often what I'll use in that frontline setting, thinking about long-term durability, my next choice is really one of how urgently do I need disease control? If I really urgently need disease control, someone's disease is really taking off where I'm worried they might not live to see another line of therapy, go for what I think might be the highest potency. For the vast majority of my patients, I try to strike that balance and say, okay, how can we try to get you on drug and get a high chance of effective disease control, not a high chance of the disease just taking off, but also some tolerability. That's where things like both Tivozanib and belzutifan potentially play a role. And for me, because I'm using IO-IO in the frontline setting, Tivozanib really is the drug that would be approved in that second line over belzutifan.
Absolutely. Ulka, we keep talking about side effects and tolerability. Can you touch on the dosing as well in the step down? I know, Rohit, you brought up the 3 weeks on, 1 week off with Tivozanib, the starting dose of 1.5 or 1.34. Is there a step down? What does that look like in your practice?
Yeah, so there is a step down. So the starting dose is 1.34 milligram daily, and then it's 3 weeks on, 1 week off, given the longer half-life of Tivozanib. The 1 week off is a very good break, and patients feel, again, it contributes to their better quality of life because they get that 1 week where they're free of medication and, able to catch up in some of the toxicities that they're having. The -1 dose, so the dose reduction level is 0.89. So there is 2 dose levels, 2 separate pills, and that would also be the 3 weeks on, 1 week off. In terms of duration, if you need to reduce the 3 weeks to 2 weeks, those are different ways to customize therapy. If you notice that your patient is benefiting, having some chronic longer-term side effects that you want to adjust and individualize patient therapy.
And Brad, on your end, if you're leaning into other TKIs like cabo or lenvatinib, starting those, we're often worried about 60 milligrams in cabo being too toxic. Lenvatinib at higher doses is also very toxic. What's your starting dose for other TKIs?
Yeah, I generally follow the data and start at the highest dose. We had data for len. Granted, it was an interesting trial, but starting at 18 versus 14, and I think starting at 18 seems to be the right choice. But to that point, again, it just comes down to education, right? I tell patients when I start, listen, we're going to start at this dose. There's a 50 to 60% chance you're not going to tolerate this. But if you can, that's the dose you need. And so if you feel bad, don't be a hero. Hold it. Give me a call. And you can do quick dose reductions. I find that to be a much more effective strategy than starting low. If you start low, you never can go up because the patient feels okay. Why would they want to try a higher dose? They're feeling well right now. But you don't know that you may have better disease control. We know that dose matters. So I tend to start high, but educate the patient very early on that, hey, you may not tolerate this. Now, that's not true with Tivo, right? Tivo, 20% don't tolerate the higher dose. So most patients, hey, you're likely to tolerate this, but if you don't, we'll reduce that dose. And especially with that week off, you can figure out they don't tolerate in the week off anyways. But with the other TKIs, I think it's just really important. I do say start at the dose that's been studied. And I tell patients these drugs showed incredible efficacy and outcomes with the understanding that over half the patients had a dose reduced. So it's not a problem. This is to be expected. The trial got these results with those dose reductions as part of that. And so I just think educating patients. I think patients don't want to give up on something too early. They feel that they stop it, they're not doing the right thing. And I think making sure we're all together, hey, my goal is not to torture you with this drug. My goal is to control your cancer. And the best way to control that cancer is to give you the drug long term. And if you push the dose too long, then you hold it and you're not getting the same amount of drug. So paradoxically, holding and quickly dose reducing is the best path forward to long-term success to maintain that dose intensity long-term, which is what we hope to do for our patients.
And again, we know from here, as you mentioned, Brad, that a tumor response is dependent on the dose itself you're using. What we have seen, Rahul, from breast cancer is abema or ribo, if we are to utilize lower dose, the responsiveness, we are not affecting the efficacy that much,
that is
but
true.
in kidney
Here.
cancer, it is being affected. So again, starting out with a larger dose. David, is that your approach as well, or you start off with low and then go high?
I start off with the standard dose. The study 218, lenvatinib starting at 18 milligrams versus 14 milligrams was eye-opening. When you do appropriate dose reductions, there wasn't a higher rate of overall toxicity when you started at that higher dose. And numerically, at least, it seems like there's potentially more efficacy. The key is that sort of proactive counseling, because I think patients, there's data on this. They're worried about sometimes even telling their side effects to their physician because they're going to be told they have to reduce the dose. So that's sort of proactive counseling, saying it's not a failure if we have to reduce the dose. In fact, for things like lenvatinib everolimus, 70% of people will have to go down on their dose. And so the expectation is that will happen, but we don't know what the right dose is for you. Start at that full dose and know that it's not a failure if you have to work your way down.
And I think that just reiterates that not all TKIs are the
Yes.
same, even though we often put them all together. That is unfair, that all TKIs have very different side effects, they have different targets, and they have different tolerability.
Right. One has to acknowledge patient-shared decision-making is the key, especially when we have multiple treatment options available here. Well, before we close, can we please go around in a virtual circle to get two things from each of our panelists? David, I'll start off with you here, where the two things that we'll be focusing on, one, that trials that you're excited about and you're actively recruiting for them. And second, your key takeaway from the discussion today.
I'll mention a few because I want to make sure I don't leave anyone out. Obviously, with Brad here, the one I'm most excited about is STRIKE in that adjuvant setting, which is a randomized trial in the adjuvant setting comparing pembrolizumab versus pembrolizumab plus tivozanib. I think really exciting to see how this combination performs with the sort of short 6-month addition of tivozanib. In the frontline setting, we have some newer agents like the HCR Architect trial, but actually a really, I think, critical thing for the field is understanding the role of cytoreductive nephrectomy. And Ulka is doing this amazing job leading the PROBE trial out of SWOG that we have open here as well, that I think will answer just a critically important question for the field. And then finally, in the refractory setting, a lot of what we focus on here is novel immunotherapies. I think there's lots of new things coming down the pipeline, both in terms of newer versions of targeted therapies, new TKIs, new HIF2 inhibitors, but also new types of immune therapy like T-cell engagers. We're recruiting for all of those at Yale, but I think there's a series of important trials that are going to be reported in the coming years.
Thanks for covering that. And key takeaway from the talk today.
So I think the key takeaways for me are really patient education, being proactive about that, and letting them know that these are the side effects that might happen. They might not for sure, but they might happen, so they're aware of it. And it's not a failure to address those and reduce doses. That's going to be the norm for lots of patients, depending on the TKI. And for other TKIs, we might not have to address it nearly to the same extent because they have a lower toxicity rate to begin with.
Patient education is the key, and patient-shared decision-making is the key along with that, especially when we have multiple treatment options available. Ulka, things from your end, ma'am.
Yeah, the key takeaways, I'll start with that first. And I totally agree that to the points that Brad stressed about, proactively telling patients and reassuring them that it's okay to reduce the dose, because that is a big worry, both in the patient's mind and our mind, that they won't be transparent with us about their toxicities. It is a matter of customizing the dose eventually, but starting at the standard dose is also critical, as David mentioned, given that there are studies showing that dose intensity matters in getting us optimal outcomes. With regards to the clinical trials, I thank David for giving us that pitch about SWOG 1931, which is a study of upfront immune checkpoint-based regimen and then randomizing to nephrectomy or not. This is a study that no pharma company is going to do, and we will hopefully be able to find out if radical nephrectomy matters in patients with metastatic disease. The other interesting pathway that we are exploring on a national level through SWOG is going to be the microbiome pathway. with immune checkpoint-based regimens, whether it be a TKI IO-based regimen or an IO-IO, to combine it with the microbiome impacting agent and see if that makes an impact on the toxicities of immune therapy, delays resistance or prevents resistance, and enhances the efficacy. Those would be the frontline trials. In terms of second, third line trials, we are hoping to do a study of Tivozanib with belzutifan, so combination of TKI and HIF-2 alpha inhibition to see if the combination would be something that improves outcomes over single agent therapy.
You know, microbiome is a hot topic in almost every disease site. Ulka, thank you. Brad, to close, studies that are actively enrolling that you're excited about, and then finally your key takeaways from today's discussion.
Yeah, I mean, really just build upon what we talked about here, right? I think the tolerability of tivozanib is what sets it apart. And so obviously reading this trial, I'm most excited about Strike trial, NCI trial, AO32201, which again is looking to say, you know, when you look at the adjuvant therapy with pembrolizumab, you could say we're over-treating patients, but you also say we're under-treating a lot of patients. There are a lot of patients who, despite pembrolizumab, still relapse, and how can we do better? And I think one of the things that plagued TKIs in the adjuvant setting was tolerability, need for dose reductions, need for early cessation. And so given the success of IO-TKI in the metastatic setting, it really makes sense to explore combinations. And so again, Strike's looking at a year of pembrolizumab with about 6 months of tivozanib. And so I'm hoping that this lays the foundation for an effective doublet in the adjuvant space. We have a press release doublets can be effective in the adjuvant space with belzutifan and pembro. And so I think this is a very effective, hope to be a very effective doublet to improve outcomes. Beyond that, you know, trying to prevent recurrences, I think that as we look to the future, there's a lot of data coming. So we're going to have, you know, we have doublets. Now we're going to have potentially triplets with like lem-pembro belzutifan or lem-pembro CTLA-4, that large phase 2 trial. We'll see results. And I think HIF-2 is the story. We've talked about novel therapy, but I think HIF-2 is going to be the story. How does this really come into play? And so belzutifan is firmly established, but casdatifan, another HIF-2 that's being explored in a variety of different settings with cabo versus cabo alone. And so I think to that point of how do we get the best disease control with the best toxicity profile, and how, as we look at these doublets, if we improve outcomes at what cost? And what is the toxicity? What is going to be the expense to our patients? So I think there's going to be a lot we're going to learn from these trials as we move forward, as we start thinking about doublet versus single agent. We know in breast cancer that doublets offer superior efficacy, but when you look at it overall, increased toxicity, you can do sequential. So how is this all going to play out in kidney cancer? I think now that we have combinable agents, we're going to be asking those same questions, and I look forward to doing that. In terms of tonight, I think the metastatic space for kidney cancer is evolving, and what you choose second line absolutely depends on what you chose frontline and how that patient tolerated and where the disease at. And so I think it just really does highlight when there is no right answer, every single thing matters, right? The patient preferences, how easy it is for them to come in, all those different factors truly do matter. And even TiVo, the fact that you get a week off, patients love that. There's a week, they don't have to think like they have cancer, right? They don't have to take a pill every day. And so some of those even mild things can make a huge difference. I do think having those discussions with the patients, educating the patients, and making sure that they understand we're all here to do the right thing for them is the way forward.
Keeping the patients at the center of this is what we're all talking about. And we've touched on a few clinical trials. I really think all these trials will shape the future of RCC, and this treatment landscape will look very different in the near future. Thank you all for your thoughtful, practice-focused insights today. To recap for our listeners, tonight we've touched on key second-line options after IO-TKI and RCC, where treatment is with palliative intent. We've talked through sequencing strategies and the importance of side effect management. So picking that right treatment option for that patient in front of you is important. Thanks to our fantastic panel and to our listeners for tuning in. For more practice-changing data, discussions around standard of care, and challenging cases from community, continue to follow us along on our platform, the Oncology Brothers.